So imagine going to the doctor because a part of your body feels, well, completely broken. It's failing you, it's ruining your quality of life. And, with absolute certainty that something is physically falling apart.
Right, you can feel it.
Exactly. You feel it, but then the doctor measures it and they tell you that structurally it's perfect.
Oh, man. Yeah, that's incredibly frustrating for a patient.
It is, because usually when we talk about a medical diagnosis, there's this expectation of like absolute precision, almost like engineering. You break your arm, the x-ray shows that jagged white line, and the doctor just points and says, there it is.
Yeah, it's a comforting thought, isn't it?
Mhm.
We really like our medical issues to be visible, binary, and just neatly categorized, like broken or not broken.
Right. But today, we're exploring a stack of clinical guidelines, physiological studies, and neurophysiology papers focused on an area of the human body that completely breaks that X-ray machine. We're looking at the highly complex and honestly often misunderstood world of the pelvic floor.
It really is the ultimate diagnostic puzzle.
It really is. So the mission of this deep dive is to unpack a very specific, high-stakes medical mystery. We're looking at how doctors distinguish between tissue laxity, which is a physical, structural issue, and numbness, which is a completely hidden neurological issue.
Yeah, the pelvic floor is essentially this hammock of muscles, connective tissue, and nerves holding up your vital organs. When patients come in, they often present with these incredibly vague, distressing sensations.
Like what kind of sensations?
Well, they might describe a feeling of looseness or a severe reduced sensation or a feeling that things just aren't physically supported down there anymore.
Okay, let's unpack this, because if I go to the doctor and say, my shoulder feels loose and unsupported, the doctor's first thought is that the joint is physically damaged.
Naturally, yeah.
But in the pelvic floor, you're saying the underlying mechanical reality causing that feeling of looseness could be completely different from what the patient's brain is telling them.
Radically different. I mean, the stakes for getting this right are massive. Treating stretched tissue when the real problem is, say, a compressed nerve is like trying to fix a faulty electrical wire by painting your walls.
Oh, wow. So it just completely misses the mark.
Completely. It won't work. The patient is left incredibly frustrated, and they might even start to feel like they're going crazy. So to understand how doctors actually solve this, we first have to understand the vastly different biological realities behind these symptoms. We have to separate the physical structure from the electrical wiring.
So we're talking about three main culprits in the research here. There's laxity, weakness, and numbness. Let's start with laxity. What is actually happening in the body there?
So laxity is a purely structural alteration. It happens in the mucosal wall matrix and the fascia, which is basically the dense connective web holding everything in place. The collagen and elastin fibers in that tissue become permanently overstretched. This usually happens from the sheer mechanical trauma of childbirth or from severe estrogen depletion during menopause, which really thins the tissue out.
So it's a physical change.
Yeah, it causes a literal anatomical expansion of the canal and a significant loss of physical friction.
So the physical fabric is permanently stretched out. It's lost its elastic snap.
Exactly.
But what about weakness? Because I hear people use weakness and laxity interchangeably all the time, even in medical contexts.
Oh, they absolutely do, but merging those terms is a massive mistake.
Right.
Weakness is a neuromuscular issue. The actual muscular slings supporting the pelvic organs, the levator antemuscles, they lose their active tone.
Oh, I see.
Yeah, they fatigue quickly, or they fail to contract properly when under stress. That leads to issues like stress incontinence, where a sudden pressure, like a cough or jumping, causes you to leak urine.
Because the muscle just couldn't fire fast enough to hold the gate closed?
Right, it wasn't strong enough.
Okay, so that's two very different mechanical problems. Laxity is the connective tissue stretching out, and weakness is the muscle failing to squeeze. But then there's the third layer, which seems to be the trickiest.
Yes, numbness or neuropathic dysfunction. This is entirely a wiring issue. It primarily involves the major nerves at the base of your spine, specifically the pudendal nerve.
Which goes where exactly?
It branches out to the vulva and the anal area. And then there's the sacral nerves, S2 through S4, that act as the main communication cables for the pelvic floor.
Okay.
If those nerves suffer compression or entrapment from scar tissue or just direct damage, the sensory transmission is altered. The nerve simply isn't sending the right data up to the brain.
So what does that feel like?
It can manifest as pins and needles, a total deadening of feeling, or even paradoxical severe pain.
So if we think of the pelvic floor as a house, laxity means the foundation itself has been stretched out and physically widened. Weakness means the support beams are sagging because the wood is rotting. But numbness means the drywall is fine, the support beams are perfectly strong, but the electrical wiring behind the walls has been chewed through by mice.
I think you're on the right track with the house analogy, but let's take it a step further. It's not just that the wires are chewed through, it's that the security system is sending false alarms to the homeowner.
Oh, that's awful.
It is. And if we connect this to the bigger picture, you can see why understanding this distinction dictates the entire treatment plan.
Because if the support beams are sagging, the muscular weakness, you need to reinforce the beams.
Right. The patient requires specialized pelvic floor muscle training, PFMT, or Kegels, to build that active muscular tone back up.
But if the foundation is stretched out like true connective tissue laxity, no amount of muscular squeezing will fix that overstretched collagen.
Exactly. You can't exercise a stretched ligament. Those patients might require thermal or laser energy to physically remodel the collagen under the mucosal layer.
And if the wiring is faulty, the nerve numbness Kegels and lasers are totally useless.
Completely useless. They need specialized nerve blocks or even surgical decompression to free the trapped nerve.
You really have to know exactly which part of the house is broken before you bring in the tools.
You do.
But that brings us to the core mystery of the sources we are looking at. If these issues require such drastically different treatments, why do patients get misdiagnosed so often? I mean, why is it so hard to just ask the patient what's wrong?
It comes down to a really difficult truth. Patient self-reporting is surprisingly unreliable when it comes to the pelvic floor.
Really?
Yeah, we intuitively trust what our bodies tell us, right? If we feel structurally loose, we assume we are physically loose. But doctors were getting increasingly frustrated because they were seeing patients who complained of severe looseness, yet their physical exams looked completely normal.
Wow.
This disconnect led to a landmark piece of research. It's called the Development Study Description of Vaginal Laxity and Prolapse and Correlation with Sexual Function.
Oh, right. This is the study that completely upends how we think about human sensation. How did they set it up?
So they evaluated a large group of women using a subjective questionnaire, the Vaginal Laxity Questionnaire, or VLQ. It simply asked patients to score their own internal sense of physical laxity on a scale from 1, which represented feeling very loose,
Okay.
up to 7, which represented feeling very tight.
That makes sense. You just ask someone how they feel in their own body, and they give you a number based on their lived experience.
Right. But what's fascinating here is what happened when they compared those subjective VLQ scores to objective physical measurements.
What did they measure?
The doctors performed highly standardized physical exams. They literally took out a ruler and measured the actual physical descent of the pelvic organs, looking for prolapse or a POP, and they measured the physical gap of the genital hiatus.
And what did they find?
The shocking result. The subjective scores from the patients did not correlate at all with the objective physical exam findings.
Wait, I really want to pause on this. You're saying a patient could score themselves of 1, meaning they walk through life feeling incredibly loose to the point that it's dominating their daily thoughts. But a doctor looks at their physical anatomy, measures the tissue, and finds that everything is perfectly anatomically tight and in place.
Yes, there was absolutely zero statistical correlation between what the women felt and what the physical tissue was actually doing.
That is mind-blowing, and honestly, it sounds incredibly isolating for the patient. I mean, imagine feeling like your body is failing, but the medical tests say you're completely fine. Were these patients just hypersensitive, or was this actually impacting their lives?
Well, it was heavily impacting their lives, and the study proved that too. They also measured sexual function using the Female Sexual Function Index, the SFI.
Okay, and a low score, and that means what?
A low score, specifically under 26, indicates clinical female sexual dysfunction. The study found that the average score in this population met the criteria for severe sexual dysfunction, regardless of whether they felt tight or loose on that initial questionnaire.
Oh, wow.
Yeah, their suffering was entirely real. Their quality of life was genuinely compromised. But the structural explanation they were feeling, the looseness, was a phantom.
So if a patient comes in deeply distressed, feeling a profound loss of structural support, but structurally they're totally fine, what is the next move? How does a doctor even begin to solve a problem that is invisible?
Well, this raises an important question. When the structure looks normal but the sensation is wildly off, the doctor has to completely shift their mindset. They must pivot from being a structural engineer to being an electrician.
Because they have to stop looking for stretched tissue and start hunting for nerve damage.
Precisely. because the brain is getting bad data from the sensors.
And to test the wiring, they deploy a highly specific neurological toolkit. I was looking through the guidelines, and the most foundational tool they use is surprisingly low tech. It's literally a simple cotton swab.
Ah, yes, the Q-tip tests.
Yeah, but what threw me was how they start the test. They don't start in the pelvic floor at all.
No, they don't. It's a quick 5-second test to map pain and sensation. But the crucial part is establishing a baseline. The doctor starts by lightly touching the inner thigh with the Q-tip.
Wait, why start on the leg if the problem is in the pelvic floor? Are you just looking for a control variable so the patient remembers what normal touch feels like?
You hit the nail on the head. The inner thigh is not innervated by the pudendal nerve. It uses a completely different neural pathway that connects higher up on the spine.
Okay, I see.
By touching the thigh, the doctor establishes a true zero baseline for non-painful, normal sensation. Once the patient registers what a normal touch feels like, the doctor moves the Q-tip to the vulva and carefully maps out exactly where the sensation changes.
It's like finding out what the baseline voltage of the house is before you start checking the broken outlets in the living room.
Exactly. And from there, they move to a pinprick test. They take a broken wooden Q-tip and lightly press it across the specific areas of skin fed by those sacral nerves, the S2 to S4 dermatomes.
Are they just looking to see if it's numb?
Not just numbness. They're looking for two extremes. Either hypoesthesia, a decreased sensitivity where the patient can't feel the sharp point at all, or hypergesia, which is an extreme, disproportionate sensitivity where a tiny prick feels like searing pain.
Here's where it gets really interesting. Because looking at the sources, the diagnosis of numbness or nerve damage often relies on finding severe pain-like allodynia, where even the lightest touch of a cotton swab feels like a burning knife, rather than just an absence of feeling.
Yes, exactly.
My question is, how does a doctor connect that back to the initial problem? Is it common for a nerve injury to masquerade as physical looseness just because the brain doesn't know how to interpret a missing or garbled nerve signal?
It is incredibly common, and it's the root of so much diagnostic confusion. I mean, think about how the human brain interprets a lack of normal data.
Okay.
If a major pelvic nerve is compressed, say, trapped by some internal scar tissue from a past surgery, it stops sending the normal signals of friction, pressure, and support. But the brain hates a vacuum. It receives this deadened signal or this garbled, painful static, and it essentially has to guess what's happening down there. It translates that lack of normal sensory feedback into a generalized subjective feeling of looseness or a lack of support.
Wow. So the house feels like it's physically falling apart, but really the alarm system is just malfunctioning and sending a fake alert to the homeowner's brain.
Yes, the brain is constructing a physical reality out of broken electrical signals. And if the basic Q-tip tests point to a wiring issue, doctors have to go deeper to prove it objectively. They use quantitative sensory testing, or QST.
That's where they test the different sizes of nerve fibers, right?
Exactly. They use a specialized thermal probe that slowly heats up or cools down. This checks the warm detection threshold and the thermal sensory alignment. The patient just has to say exactly when they feel the temperature change.
But why use temperature? Why isn't a normal touch test enough to prove nerve damage?
Because the nervous system is highly specialized. The thick nerve fibers carry signals for heavy pressure and muscle movement, but the incredibly small, unmyelinated nerve fibers only carry signals for temperature and subtle pain.
Oh, so you could have partial damage.
Exactly. A patient might be able to feel a strong poke perfectly fine, but their small nerve fibers could be completely destroyed, which the thermal probe will reveal when they can't feel the heat changing.
That is wild. It's like testing the high-speed internet cables versus the old copper telephone wires separately.
That's a great way to put it.
And what if they suspect a major roadblock, like damage all the way up at the spinal root itself, like pudendal neuralgia?
Then they bring in the heavy neurophysiology tests, things like somatosensory evoked potential cephs or bulbocavernosus reflex testing. Instead of just asking the patient what they feel, they literally measure the speed of the electricity.
How do they do that?
They stimulate the pelvic nerve with a tiny electrical pulse and use sensors to measure exactly how many milliseconds it takes for that signal to reach the brain or trigger a reflex, like with an anal sphincter EMG.
So they're literally clocking the speed of the nerve signal.
Yes. If the signal takes too long to travel, or if the electrical wave is too weak when it arrives, it provides objective, quantitative evidence that the nerve is compressed or injured. The patient isn't imagining things. Their wiring is objectively compromised.
Okay, so let's flip the script. The doctor has mapped the nerves, checked the electrical speed, done the thermal testing, and the nerves are completely fine.
Good.
The electrical system is flawless. Now, the doctor has to definitively prove if there is a true physical structural issue, the laxity, or a muscular issue, the weakness. How do they shift back to being a mechanical engineer to figure out which physical part is failing?
Well, they have to go back to physical measurements, but they have to isolate the different components. To assess true structural laxity, the stretched connective tissue, they use the POPQ exam.
Pelvic organ prolapse quantification, right.
That's the one. They visually and manually map out the vaginal opening. They measure the exact distances of specific points, like the genital hiatus and the perineal body, in centimeters. But crucially, they don't just do this while the patient is resting. They measure it while the patient is performing a Valsalva maneuver.
And that's the medical term for when a patient bears down, like they are trying to have a bowel movement or push during labor.
Exactly. Bearing down puts maximum intra-abdominal pressure on the pelvic floor. If the connective tissue matrix is healthy, it will hold firm under that pressure.
And if it's not?
If it is stretched and lax, the doctor will actually see a physical, measurable widening and descent of the tissue under that pressure. It proves the structural foundation has lost its integrity.
Okay, that makes sense for the connective tissue. But what about testing the muscle strength? How do you isolate the muscle firing from the stretched out tissue it's attached to?
To test for weakness, that neuromuscular loss of tone, they have to measure the patient's voluntary squeeze. They use a standard called the modified Oxford scale.
How does that work?
The doctor uses digital palpation, asking the patient to squeeze their pelvic floor muscles around the examiner's fingers. They grade that squeeze from a 0, which is absolutely no muscle contraction at all, up to a 5, which is a powerful, sustained contraction that actually lifts the fingers upward.
The sources mention that the mean strength in a lot of the clinical studies is around a 2.74 out of 5.
Which is relatively weak, yes. It indicates that a lot of people walking around have significant muscular fatigue. But a physical exam by hand can be a bit subjective. So to be absolutely certain the patient is recruiting the right muscles, doctors often use real-time transperineal ultrasound.
Wait, they can watch the muscle contract in real time?
Yes, they place a probe on the outside of the body and actually watch the pelvic floor muscles move on a screen. They can verify that the patient is doing the squeeze and lift components correctly, rather than just bearing down and pushing the wrong way, which is honestly a very common mistake patients make when trying to do pelvic floor exercises.
Okay, let me make sure I have this straight, because for you listening, this feels like the ultimate diagnostic key. If a doctor asks you to squeeze and you score a 4 or a 5 on that Oxford scale, meaning your muscles are incredibly strong, they're firing perfectly on the ultrasound, but you still feel like things are totally unsupported or you're leaking air, that is the smoking gun for true tissue laxity.
Yes.
Because your muscles are pulling with all their might, but the collagen fabric they're pulling against is permanently stretched out.
That is exactly the smoking gun. Your engine is powerful, but the transmission belt is loose. And finding that exact root cause is vital. If a patient has a 4 out of 5 on the Oxford scale, their muscles are perfectly healthy. Recommending standard Kegel exercises for that patient is entirely useless.
Right, because you can't strengthen a torn piece of fascia by squeezing the muscle next to it.
Exactly. And similarly, if the root cause is a damaged pudendal nerve sending a ghost signal of looseness to the brain, Kegels won't fix that either. It just leaves the patient frustrated.
So what does this all mean? Let's recap this incredible detective story. We've explored how doctors essentially have to become dual-threat investigators to solve the mysteries of the pelvic floor.
They really do.
They use Q-tips, thermal probes, and electrical speed tests to trace the wiring, hunting for numbness and nerve damage that masquerades as structural failure. And they use the modified Oxford scale, ultrasound, and pressure tests to check the physical foundation, carefully separating a weak muscle from a stretched-out piece of connective tissue.
Yeah, they are constantly working to solve a highly complex sensory puzzle, stripping away the patient's subjective feelings to test the actual mechanical and neurological hardware beneath.
And for you, the listener, whether you are dealing with a mysterious physical symptom or you're just fascinated by how the human body works, this matters immensely, because it proves that taking our bodily sensations at face value can actually lead us down the completely wrong medical path.
It's true.
We instinctively trust our feelings, but sometimes getting the right treatment requires acknowledging that our brain might be giving us faulty data. You have to know if you're fixing the drywall, the support beams, or the wiring.
Absolutely. And, if we connect this to the broader human experience, it leaves us with something quite profound to consider.
What's that?
Well, if a patient can feel a profound, life-altering sensation of physical looseness, a feeling so real it dictates their daily life, that doesn't actually exist in their physical anatomy, but is instead just a ghost signal from a pinched nerve.
Mm.
What other physical feelings in your daily life are just your brain mistranslating a biological signal?
Oh, wow.
Yeah. How much of what we physically feel as absolute reality is actually just an illusion constructed by our nervous system trying to fill in the blanks?